Hi, everyone. This is Jan Manwright with Cancer ABCs at our webinar series called Prostate Cancer ABCs. And we're getting ready for our next session here with Dr. Adewale Fawole. Sorry, I think I got that right. Did I do that okay, Dr. Fawole?
Yes, ma'am.
Thank you. And he is a medical oncologist, and he's going to help us on our next subject, which is PSA rising on hormone therapy. What's next? Metastatic as opposed to non-metastatic. I want to tell you what we're going to try to do for you in this webinar. The first thing is we just let you know what we cannot do. We cannot give you medical advice, and neither can Dr. Fawole. For you are not seeing him in clinic. He is a speaker today. However, that's okay because there's so many things that we can do for you. So our effort is to help you understand your own situation in cancer better, help you understand both risks and benefits, side effects and effectiveness of treatments and even of tests, help you develop better questions for your doctors and nurses and pharmacists, because better questions that you develop are what get you the better answers that you need. All of this is how you develop a strong understanding of shared decision-making. You share in the decision with the doctor. So that's what shared decision-making is, which is, by the way, a very understandable term for us as patients and caregivers, but it's also a medical term. It's written into guidelines for prostate cancer all across the board. So use that phrase, research that phrase, and learn about it. I want to thank our sponsors. We've got Astellas and Pfizer, Janssen Oncology, Dendrian, and Sanofi Genzyme. So we appreciate their support. So I'm going to stop sharing my screen and make Dr. Fawole. Joel, can you make him a co-host so he can share his? And then I will introduce him. So Dr. Fawole is a medical oncologist, and we talked about how Dr. Mall was a urological oncologist or urologist. We talked about how Dr. Keller was a radiologist who reads imaging. Now we have Dr. Fawole, who's a medical oncologist. And what's a little bit different about medical oncology as opposed to urology is they are trained and board certified in internal medicine. You'll find that the clinic is a little bit different. You can get your blood drawn in clinic. Sometimes you can in urology, sometimes not. You'll find that they have a nurse practitioner or a PA that is part of the clinical visit. And I just think these are facts that are important for patients to know, because you need to be able to pick the physician that works best for you in your situation. So there is a difference between medical oncologists, urologists, and other physicians. Always ask, it's always a good idea. Dr. Fawole holds certification in the following American Board of Medicine specialties: internal medicine, hematology, and medical oncology. Since joining Florida Cancer Specialists at the Villages and Leesburg offices in the year 2018, Dr. Fawole has been actively providing compassionate, world-class hematology and oncology care to his community. He is involved in patient education, clinical research, and patient advocacy. Dr. Fawole has special interest in caring for patients with breast cancer, prostate cancer, and lung cancer. Today, we're going to talk about prostate cancer. His research work includes colon cancer, lymphoma, breast cancer, brain cancer, multiple myeloma, and other cancer-related conditions. His works have been published in numerous peer-reviewed journals, including the Journal of Clinical Oncology. He is a member of the American Society of Clinical Oncology and the American Society of Hematology. Welcome, Dr. Fawole. You can share your screen whenever you're able to.
Thank you for having me.
Thank you for being here.
All right, let's see. Share my whole
There you go.
Okay.
Perfect.
Okay, good. All right, so thank you for having me, and it's always a pleasure whenever I have opportunity to talk to uh, patients about their condition and their caregivers as well, because we know we're not doing this alone, so we appreciate every help along the way. I see that in the year 2021 to be an injustice to discuss managing prostate cancer without going into a little bit of details about, the next generation things that we do now, which include next gen sequencing, looking at the molecular profile of the cancer, the genetics of the patient, and by so doing, try to figure out what's the best way to treat the patient. Now, what I'm sharing with you is the framework that's been developed by my partners. I've worked in cancer network, so I know the importance of how we all come together and try to have a standardized way of treating patients. These are guidelines. They are not like so rigid, but it's to guide our profession so we can be sure that we're providing good care to patients. So most of what I'll be sharing with you, they are from the NCCN guidelines. Now, we paid close attention to the patient's history of cancer. We do what we call germline testing, which in many cases is clinically indicated when prostates have certain types of, when patients have certain types of prostate cancer. On my slide here, you see that patient with metastatic cancer. We want to do germline testing. And what that is testing is, do you have any inheritable condition or predisposing thing, situation that's going on that you may have inherited from either of your parents that's responsible for the disease. So we will generally offer this to patients with metastatic cancer if they have advanced disease where their lymph nodes positive, or if we consider them to have very high risk localized prostate cancer. Family history is also important. Your first, second, and third degree relatives. We want to know if anyone has breast cancer at any age. At any age younger than 50, at age younger than 50, I mean, breast cancer at age younger than 50. So it's not enough to know that your family member has breast cancer. We also want to know, like, how old were they when they had the cancer? So, and it's important. I like this idea of bringing somebody who knows you and your family history to your doctor's appointment. I think it helps, or at least get as much information as you know. If you show up at the appointment and you don't remember some of this information, that's okay. Next time you come in, I mean, I'm sure you weren't expecting some of these questions. People just show up, they didn't know what we were gonna ask. And then we're asking them about family history. You can always go back home, try to recall and refresh your memory. And if you have updated information, let us know, because we use that to decide the pathway for treatment. I can't tell you how many times patients have shown up and I'm asking them, any family history of cancer? And they're like, no. And then the spouse is like, oh, what of your this? What of your uncle? What of your son? And then we realize, oh, so there was actually some history which they can't remember. So that's very important. Now, as I was saying here, we also look at history of colon cancer, because some of these cancers, we realize that there may be certain genes that connect them with prostate cancer. Ovarian cancer, if a man has breast cancer, then we want to know about it. And in many cases that I've treated patients with male patient with breast cancer, usually there's some genetic situation underlying their disease. If you have first degree relatives with prostate cancer at age younger than 60, we want to know about it. If there are conditions like Lynch syndrome, and Dr. Lynch, a very brilliant doctor, a lot of good work that help us to understand how colon and rectal cancer, endometrial cancer, pancreas cancer, how they can all be connected. So these are tests that I order for patients when appropriate. And then it's also important that we know if you know your family history of pathogenic, by that we mean mutation that's been found in other family members who had cancer, like BRCA1 gene. I'm sure many of us will know about the story when Angelina Jolie had to have some breast surgery based on her family history of breast cancer and the presence of BRCA gene in the family. So based on that information, of course, I remember then we started having a lot of patients coming to us and say, hey, what's my history? Do I need to have breast cancer surgery, things like that? Some of my colleagues termed it, they said it's Angelina Jolie effect. But that's just to highlight the importance of letting patients know the connection between their family history and their risk of cancer. Ashkenazi Jewish ancestry, for some reason, they have some foundation mutations that's passed along in the family line, and it's important that we know. And also jump to germline testing. As you can find here, that's germline testing. We may consider that in patients when they have personal history of prostate cancer in the following setting. We look at the characteristics of their cancer. We look at the histology, if they have intermediate risk prostate cancer, and introductory or cribriform histology. We know that these people may have a higher risk of a higher tumor mutational burden, which will guide our cancer treatment. And then if they have a prostate cancer and a personal history of any of the following, like they have pancreatic cancer, colon cancer, or melanoma. I can't tell you how many times I've asked patients, did you have skin cancer? And they don't even remember, or they don't know. And it's important to tell us whether it's just basal cell or melanoma. So it's important. So please be involved in your own care. It helps us a great deal. And then by somatic tumor testing, we mean that we actually look at the tumor specimen, and we are looking for information that will guide us to let us know, use these certain drugs or use this certain treatment to take care of the patient. I mentioned earlier, like tumor testing can include homologous recombination DNA genes. That include the BRCA1, BRCA2. I found ATM gene recently within the past few weeks. So these are some of the genes that I found, and I've actually found BRCA gene, ATM gene in my patient with prostate cancer. And based on that, we can recommend use this treatment or that, and I'll talk about that again shortly. Then it's also important, we talked about post-test consideration. We want to know, depending on what we find, we can advise family members, go do this test or go do that, so we can hopefully prevent development of cancer in younger and other family members. So those are things that we can always discuss. Now, let's look at this case. We have a patient, 62-year-old gentleman who underwent radical prostatectomy 18 months prior for pathologic Gleason score 9 adenocarcinoma of the prostate. And now he presents with 1 month history of mild left hip pain. His PSA is 21. It's been up from 10 nanogram per milliliter 6 months prior. And then he had a bone scan that showed a focus of metastatic lesion in the left femur, corresponding to the site of pain. Current medications include Lupron, lisinopril, and he lives with his wife. He rides bicycle for 3 miles 5 days a week. So we describe this as a very active patient, well-educated patient, and asked, hey, is there some immunotherapy and how would that be of help in my situation? So here is our answer. We know about Provenge. It's one of the options, actually the first one for prostate cancer. Now we do a lot of immune therapy, but I think this is one for prostate cancer. Sipuleucel-T, I think that's the name for Provenge. It's an autologous dendritic cell therapeutic vaccine designed to enhance the immune T cell response to PAP, the prostatic acid phosphatase. Of course, there's a lot of complex mechanisms underlying how it works, but in a randomized trial, it prolonged survival of patients when it was compared to placebo dendritic cells. And it was believed to have a favorable safety profile. There's a complex process to prepare it, but it just entails collecting blood from the patient. It is processed, and 3 days after harvesting the blood, the patient comes back and gets infusion of their own blood, but now with some processing to, I guess, enhance how it works, just to put it simply. So there was this phase 3 impact trial. But in my world, we do have different phases of clinical trial that leads to drug development. You want to check, is this drug safe to administer to human beings? Does it work? Even after the drug has been approved by FDA, we still continue to monitor that phase 4 to know whether it's safe, it's working, it's doing what it's supposed to do. For phase 3 randomized trial, that's a very high level of confidence that we have in our studies to prove that medications work. So that's why, and let me quickly mention this, many times you hear patients ask, oh, can I use this medicine? Or I saw this online on Amazon, or my friend was using this herbal remedy or some alternative medicines, some vitamins. Can I use it for my cancer? It's a little bit challenging to answer that question, because unless those who are selling those drugs have put them to the same type of rigorous test that we do, it's difficult for me to tell you, oh, it works, it's good. We can tell you based on our rigorous clinical trials that the effect that we get is not by chance. So some of the numbers that I'll be giving you today might look like, oh, are they just talking about 4 months survival? No, it's much more than that in the real world. But at least we're able to prove a concept that this medicine works and it's not by random chance. So just note that. Now, so for this particular study, they followed the patient for about 34 months, and then the median survivor, again, median is in the middle. It's not everyone. Some people will live longer, some a little bit shorter, but it's the median. So just remember that. So in this study, median survival was 25 versus 21 months. So those who received Provenge had 25 months survivor, whereas those who did not, theirs was 21.7, with the risk of death with the risk of progression being 22%. Now, in post hoc analysis, trying to see what works and what doesn't work, it's believed that patients who have lower baseline PSA, not a patient with 10,000 nanogram per milliliter, lower PSA numbers, they are likely to benefit more from the study. What's the role of Provenge in prostate cancer? Well, we use it for asymptomatic or minimally symptomatic patients, like in the patient described in this case. If they have no disease in their liver or other organs like the lungs, yeah, may be applicable to them. If they, we know that significantly prolonged overall survival. So they were able to show that, yes, patient actually lived longer. But know that it's rarely induced disease regression. So patients, and let me say that they did not have perceptible effect on radiographic progression-free survival. By radiographic, we're looking at what do we see on the imaging? Did they have a lot of disease before we started treatment? If we do a scan in 6 months, are those lesions gonna disappear? Don't be disappointed, they may not disappear when you use Provenge. It did not induce consistent changes in serum PSA. So patient may come in with a PSA of 50, and it may even continue to rise after the treatment. So the absence of these objective parameters is a challenge for many practicing oncologists to know whether this medication is working or not, because how do I know if my patient is getting worse? No, not many people use Provenge, but it's an option, just so you know. But I have to say that using pembrolizumab has actually been a revolutionary drug in my world since we started using it in malignant melanoma. So we've been using it, and now it has a space in prostate cancer, but very small group of patients. It's not for everybody. And when you hear us talk about immunotherapy, this is what we're referring to many times. It's only for patients who have MSI high. MSI is the type of test that we perform on the tumor specimen we can have MSI high or low. Or if they have deficient mismatch repair, that's what I mean by DMMR. So those are the ones who are likely to respond. That's not everybody. Actually, in one report where they looked at 12,000 cancers, only approximately 4% of those in that group has what we're looking for, either the deficient mismatch repair, which is same technically as MSI high. So, and that was also confirmed in more than one group of studies. And a somewhat lower prevalence of 1 to 2% has been reported when you limit those analyses to patients with advanced metastatic disease. I don't know if you recall, I mentioned earlier that patients with intraductal and high-grade prostate cancer, they should undergo testing so we can tell, hey, what else is going on here? Do they have deficient mismatch repair? Because they might be eligible for this. This is what I look for as a doctor. So I wouldn't expect patients to try to figure out, do I have pre-formed prostate cancer or not? I think that's a little bit too much, but we definitely look into that. And it's okay if you have your histology results, ask questions, that's okay. And then I also want to talk briefly about targeted therapy. Olaparib, this is called a PARP inhibitor. It's being used commonly in patients with breast cancer or ovarian cancer. It's also find its space in patients with prostate cancer. In this case, we use it when there's metastatic castration-resistant prostate cancer, and if the tumor also harbor like the homologous repair gene mutation. Example of that would be your ATM gene, your BRCA gene. So this drug can be used for those patients with good success. We combine it with androgen deprivation therapy, or for those who had surgical castration, that's also okay. Rucaparib is in the same category. It's also a PARP inhibitor. So it's good when we have more than one drug option to use for our patients. My second case is a 66-year-old man who has prostate cancer. It's metastatic, diagnosed a year prior, and now he presents with a 2-month history of progressively worsening low back pain. He's been on Lupron for 1 year, and lab shows some mild anemia with hemoglobin of 11.5. PSA has been rising, it's 343 nanogram per milliliter. Testosterone is high, 90. And pardon me, I think in the slide that I sent to you, I may have labeled this as castration sensitive. This will be castration resistant. So please correct that. So bone scan for this patient showed osteoblastic lesions in the lumbar spines and the sternum. So we're dealing with disease in a few sites. How do we want to treat a patient like this? And these are real life situations that we deal with every time. Now, abiraterone, Zytiga, Yonsa, whichever name they want to call it, but abiraterone acetate is something that can be used in a patient like this. We have the Latitude study. They looked at, again, a phase 3 high-level clinical trial. We try to double blind. Both the patient and the doctor don't know what medication you're taking, but the investigators know, and that's to eliminate bias. We want to make sure that we're being fair. We're not just choosing patients who is our friends. So anyway, but the important thing here is this patient showed that, this study, after a median follow-up of 30 months and at the planned interim analysis, the median overall survival was significantly longer in the abiraterone group than in the placebo group. And they're talking about a 48 38% risk reduction. I mean, that's pretty good. You don't get that all the time. And the p-value here, I mean, is 0.001. Again, very statistically significant. And there's also a delay in radiographic progression. For those who are on the medication, you will notice that more than double the risk of progression here. For those on treatment, drug was 33 months. For those who were on placebo, it was 14.8 months. So the hazard ratio, again, we're talking about 53% here. So very good drug that helped our patients. This being, we use it both in castration sensitive and castration resistant patients. In the US, we have two types, Zytiga and Yonsa. They work by irreversibly inhibiting CYP17. This is an enzyme that is involved in androgen biosynthesis. Androgen, we know that the prostate cancer is basically an hormone-driven disease. So what we're trying to do is like turn off the faucet so the cancer is not being fed, and so we can deprive the cancer cells. That's just a simplistic overview of what we do with these medicines. Now, there may be issues with food interactions when you're taking them, especially with abiraterone. You don't want to take it with a high-fat meal. Please do not, because that will increase systemic exposure up to like 10-fold. So always remember to take your Zytiga on empty stomach, or at least 1 hour to 2 hours, 1 hour before food, or at least 2 hours after food. But for Yonsa, which is a different formulation, that can be administered with or without food. So these are conversations that you can have with your doctor to see what suits your lifestyle, because it's one thing to take the medication, but we also want to take it as it should be taken so it can be effective. I also want to talk about Xtandi. That's another oral medication that we use to treat prostate cancer. We use it for castration sensitive or castration resistant, but I'll focus on those with castration resistant. In the Prevail double-blind phase 3 randomized clinical trial, 1,717 patients were randomized to receive either enzalutamide or placebo. And the co-primary endpoints, looking at radiographic progression-free survivor and overall survival. This was published in the New England Journal of Medicine in 2014. I just go straight to the results. The rate of radiographic progression-free survivor at 12 months was 65% among patients with enzalutamide as compared with 14% among the placebo. So we're talking about like 81% risk reduction. That's huge. That's quite impressive. And that's how some of these medications get their approval through the FDA, because we can demonstrate that they work. Those who got it, we saw how they did, how they fared, and those who didn't, we can see the difference. How does it work? It's a pure androgen receptor signaling inhibitor. It inhibits androgen receptor nuclear translocation. It's a very complex and interesting process, but it has to get into the cell to do its job by binding to the DNA. It goes all the way into the nucleus of the cell. But the important thing is we want to make sure that patient's okay, right? Okay, good. So how do you take it? As much as possible, you want to take it around the same time every day, with or without food. There are other questions that your doctor will ask you. For instance, in that clinical trial, some of the patients, for some reason, who had underlying history of seizures, they realized that they had more seizures. A few patients had seizures. So I'll be very cautious for a patient with seizure disorder. I would rather choose another medicine. So there are things like that that inform our decisions. Other androgen blockers, I will not take your time. Apalutamide, that's also a new one. Bicalutamide, that's a first generation androgen blocker, and they were all equally effective. We choose them based on side effects profile, what's going to benefit our patient. So history is very important. So please be as plain and open as possible with your doctor so we can know what's going on and make informed decisions. My third case is a 69-year-old man with also metastatic prostate cancer who presents with a diffuse bone pain. due to metastatic cancer. So now we're not just talking about a few pain here and there. I mean, it's all over, very sick. He's tried other lines of treatment, and now he has a rapidly rising PSA with a doubling time of less than 10 months. And by doubling time, we mean when you check the PSA, say for instance, it's 20, and then we check it again in 3 months, it's gone up to 60. I mean, that's not okay. If it's longer than 10 months, yeah, we can take our time, look at, but if it's rising rapidly, yes, we want to jump in and do something about it. So in essence, we are not just using one test result in many cases. What can we do for this patient? Well, this patient has already had chemotherapy. We can do a radiopharmaceutical agent called radium-223. It can be administered once every 4 weeks for 6 doses, and it's been quite effective and helpful. So what this does is it does alpha emission, not those long gamma radiation. It's close to where the problem is. That's where the drug is delivered, so we can get the most effect. Of course, this medication comes with the side effects like anemia, which is what your doctor will monitor and assess as you get the treatment. So the clinical trial that led to the approval of this is called Alsimca. They seem to have some very interesting name for these studies. So but that's my scientific world. So in this study, 921 patients, that's a good size of patient. And again, that shows how common prostate cancer is. Some studies, I rarely get 100 patients to participate just because it's rare. And so the more patients we have, the more studies we can, or the better our studies can be. And we can be sure that our studies are not just due to random chances. So in this study, the treatment group received 6 injections of radium-223 with a matching placebo. And so the primary endpoint was overall survival. And the results at the interim analysis, Xofigo significantly improved overall survival. It's about 14 months when compared to the placebo group, with 30% reduction in the risk of death. So that's pretty good. There is another medicine coming on the horizon that I think I should, and I'm sure you'll have heard about it at some point, but let me just mention it here briefly, especially at my institution, Florida Cancer Specialist. There is a medication that's approved so that can benefit our patient. You can be sure that we are all over it and trying to make sure we get it. Lutetium, it's a very long name, but for the purpose of this conversation, I'll just call it lutetium. So it's a radioligand therapy that delivers beta particle. You remember we just talked about Xofigo, that's alpha, this is beta. So it delivers radiation to PSMA expressing cells. I'm sure you have had a conversation about PSMA today with the radiologist. So this is expressed on cancer cells. So as much, I guess the goal here is we always want to minimize toxicity while we are maximizing the benefits to our patients. So we want to avoid collateral damage as much as possible. By that, I mean side effects. So this medication is shown to be very good from my evaluation of the studies so far. In this study, they assigned patients 2:1 in a 2:1 ratio to receive either lutetium or whatever the protocol permitted standard of care. And the results again, after follow-up about 21 months, thereabout, showed that imaging-based progression-free survival, we're looking at 8.7 months, median survival, of course, we're looking at 8.7 versus 3.4 months. That's, again, more than double, which is pretty good. But we're still awaiting FDA approval of this medicine, and once it's available, we will continue to work with the manufacturer to make sure we can deliver them to our patients who need them. I will also like to talk briefly about chemotherapy, which we use commonly in my world for patients with metastatic hormone sensitive, and actually we started using it with hormone sensitive cancer. In terms of docetaxel, we were using them in castration-resistant sensitive, but now we even use them in those who are castration sensitive. And in this trial by Dr. Sweeney et al., it showed that docetaxel is a very good viable option, especially for patients with significant disease burden. When they have a lot of disease, we want to make sure we control the disease. Patients live longer with it. When we use it in early stage, we saw a median survival of 57 months versus 44 months for the group that received just the androgen deprivation therapy only. And you can see that p-value pretty good, less than 0.001. And that's quite impressive. Cabazitaxel, that's also a taxane derivative. It's been found to be effective in managing metastatic prostate cancer. We used to give these at 25 milligrams per meter squared. Now we see that if we can give 20 milligrams, it works equally well. We combine it with prednisone. Again, the goal of our care is to make sure that patients can get good care with minimal toxicity as much as possible while we're trying to prolong life. I want to discuss this lastly as I wrap up. I came across this recently. In my world, we have to just be up to date, which I enjoy. So, but I have to read a lot to know what's going on in my community and in cancer world, so our patient can get good care. This PROPEL phase 3 trial was where Lynparza, which is olaparib from AstraZeneca, they released this result just last month, that they found that combination with abiraterone, when they combine olaparib, a PARP inhibitor, which I discussed earlier, when they combine it with abiraterone, it demonstrated a statistically significant and clinically meaningful improvement in radiographic progression-free survival. And by RPFS, we're looking at when patients get this medication, are we able to delay cancer progression? When we didn't have a lot of medicines that we use these days, some of our patients were coming with fractures due to their cancer, which still happens, but as much as possible now, we try to avoid those. So when we're using radiographic progression-free survival as a surrogate for how well the medication is doing, there's a reason for that. It's because we've seen worse days in the past, and we're trying to make them better. So, but you'll note earlier when I talked about PARP inhibitor that we were using it for patients with homologous recombination repair gene mutations, because we know that, yes, they have the activity that's needed that will likely lead to benefits. But in this study, they used it for all comers, and they felt it works. Okay, well, we'll wait and see what happened. I mean, I don't have all the information about toxicities. So there are a lot of things I'm looking at when I'm reading a medical journal to try to determine if a medication is going to benefit my patient. I'm looking at the side effects. What's the benefit? How is it going to apply to my situation and how my patient is doing? So a lot of complex things go into that. And that's the benefit for those of us who have done the internal medicine training and then we went on to do the medical oncology training, because you can look at the patient from a broad range of perspective and try to determine what's going to help us. Anyway, but we'll learn more about this, but it seems quite interesting and I feel I should mention it to you. I think that's about what I would like to know. Folks probably have questions and I'll be glad to help. Thank you for your attention.
Thank you, Dr. Fawole. Yeah, I think that people want to raise their hand. Rob's got his hand up. We can go to Rob. It was a lot of information, but it wasn't too long, so I really appreciate that. And but there is a lot for patients to absorb, that's for sure. Rob, what would you like to ask our medical oncologist, Dr. Fawole?
Dr. Fawole, thank you so much for coming and speaking to us today. You did a really, really good job going through a lot of the new medical technologies that are coming our way. My question is in regards to somebody who, if a patient, let's just say they've gone through all the surgical and radiological interventions, and now, they've had some lymph nodes removed and they're responding well on Lupron, but yet we know that they're in a metastatic state. It's just a matter of the degree, the disease progression. There's this period of time where it's like in other cancers, they seem to intervene. They go in with a chemo or some sort to try and really knock the cancer down. But with prostate cancer, we're almost taking kind of like this defensive posture and waiting for the cancer to grow and actually start to, present itself clinically. Is there any drug combinations that we're looking at now that, while the prostate cancer is sensitive to hormonal treatments, that where we can actually just go in and possibly, almost in a curative state? If you can speak to that, maybe.
Yeah, very good question. Thank you, sir. So yes, I would say many of our recommendations are based on how the cancer behaves. Okay. Now, I like to use this analogy that you don't want to, if I want to kill a mouse that I don't want in my house, I might want to use a mouse trap instead of looking for an AK-47. If you use an AK-47, you're going to kill the mouse, right? But you likely damage a whole lot of things in the process. So why don't you just set a trap? Now, I get your point that, yes, it's a matter of time. But again, everybody's different. And that's why we have to look in depth to see what else puts this patient at high risk. In the past, I know that now people growing up with iPhone, iPad, never knew that there was a time that people had to wait and write letters, or you have to go to one room to reach a phone to communicate. There was a time that when you have prostate cancer, it's just prostate cancer. So it's a lot of work. Over time now we know, okay, this is low risk, this is intermediate risk, this is high risk. So based on the risk category, we can say, well, based on how this is behaving, it's time to jump in and do something. Whereas somebody with low risk, some people may have low risk prostate cancer, Gleason score 3+3, and we'll just say, hey, you know what? Even though it's prostate cancer, we'll just keep watching you. You're not even gonna get any treatment. And some of those patients, they may die of something else. But to your point, if I have an 85-year-old man who's in good shape, who's doing well, yes, why don't we offer them whatever treatment that can be offered? So yes, we do have ongoing clinical trials, a lot of things we're trying to see. Where do we change? I think we've made some progress from putting everybody in the same basket to now stratifying to say who's high risk, who's low risk. We'll continue to do that. But we also want to think of the side effects of the medications, because as you know, many patients with, when we stop their androgen block, when we block their androgen, they start having hot flashes. I mean, a lot of side effects come with that. That's why for some patients we say, hey, use your androgen deprivation therapy, 6 months just enough. For some, we've found out using it for just 2 years is enough, because we don't want somebody who's able-bodied and doing well to be sweating all around when they go out have dinner, unless if we really have to do that. So I hope you understand our point that if the disease is not that bad, God forbid, they may die of something else that even has nothing to do with prostate cancer. So why live the next 5 years or 10 years just taking medication and being sick? So that's some of the things that inform how we make our decisions. But as soon as we have a medication with minimal side effects, gonna help patients, sure, we get on it.
Thank you. Yeah, because my question was like, I see a lot of like the men that, this becomes an issue in their, early 60s, mid 60s. Somebody like me, I was diagnosed at 49. You know, for guys like me, you know, it's a little bit more, you know, nerve wracking when we still got young families we're raising, and it just, sometimes I just feel like, you know, I look at what Europe is doing and some of these other countries in regards to scanning and actual, you know, the way they do the prostatectomies, even with you know, the amount of lymph nodes they remove. It just seems like in America, we're almost taking like this wait and see approach with it. And you know, I am happy with the lutetium 177 for a guy in my age bracket. It gives me hope, you know. So that's it. That was my thought.
Yeah, you're right. A very valid point. Yeah, but and part of that is looking, bringing to your doctor's appointment new things that you find, so that you can have a meaningful conversation. From my perspective, I welcome patients, you know, input. Hey, let us know what you're thinking, what your thoughts are. But a lot of challenges. Let me back up. So even what's generally accepted that's reasonable from scientific point of view, it's so difficult to get them through our insurance companies. And again, I hope none of you is working for insurance. I'm not here to fight you, but just to let you know that it can be a challenge to get things through.
Truth.
Yeah, so, and I don't know, I didn't practice in Europe. I hope they didn't have to, maybe their insurance agent is different than what we have here. So, but I think that's part of the hurdles we have to deal with. And you can imagine how much time we spend trying to defend this patient really needs this. We are not making enough. Look at the scans, look at this. So, but yes, that's the area of active clinical research. It makes sense for younger patients. What can we do? And I can tell you that some 8-10 years ago, we were not doing some of these tests that we now do to look at, do you have the MSI high? We weren't doing that. So we're able to tell what your risk is. We can put you in a different category and be able to treat accordingly.
Do
So,
you see? I'm sorry, sir.
Rob, let me jump in
Yep.
with somebody another question.
Yep, I'm out.
Then if there's space, we'll get you back in. Okay.
Yes.
So, so Mary asked a two-point question. Can you please mention Nubeqa or darolutamide as you describe the other third generation or second generation drugs? And also she asked, how important is it to stay on a medication until progression is seen on scans? And I'm actually going to expand that part of the question a little bit and say, how do we know when to go off medication, be it scans, or how do we know, when it's time to move on? I think that's really what the question there is.
Sorry, I didn't get the name of the drugs at the onset.
A Nubeqa, which is also known as darolutamide.
Oh, okay. And I want to believe that would have been discussed in the prior session, because that's not for castration resistant.
That's not mCRPC, it's non-metastatic, but still.
So that's the answer. Okay, so are you comfortable just briefly mentioning it and answering her question?
Sure, absolutely. Yeah, so
I appreciate it.
And actually we try to, it's amazing how they name all these medicines. You will hear bicalutamide, apalutamide, and enzalutamide. So technically they are androgen blockers. So yes, darolutamide, Nubeqa, yes. So it's available, it's an option, of course, in the appropriate setting. So it's not the same, and we don't use, actually with that, if I recall, there's not a lot of issues with seizure disorders from that study. So that's an option that we can, that can be applicable for certain groups of patients. So yes, but it's an option. It's not, that's third generation, I think.
Yeah. So thank you for going off topic, but then I guess to me, the really important part of the question is how do we know when it's time to move on to another drug?
That's multifaceted. A lot of things will come into play. First, please follow up with your doctor regularly. Be on the medication as recommended. Use we want to use with or without food. So we're even sure that in the first place, we want to be sure it's effective, because if a medication is supposed to be taken on empty stomach and you're always taking it after pizza, it's going to be a mess. So let's do those things. Now, if there's a new symptom, that will be, you don't wait until the next appointment. You want to get in touch with your doctor right away. Say, hey, I'm having this pain. And that's different than a pain that you can explain if you lift something or whatever. But if the pain is out of what is expected, yes, you want to get your doctor's attention in on that, because that may be good time to do some imaging or whatever. But regularly scheduled tests like monitoring the PSA. And I have to also say a word of caution here that it's not every time that PSA will rise for patients with metastatic cancer. I've had a few patients like that they had the low PSA, yet they still had disease. But let's leave that for us to figure out. But for those who have rising PSA, you'll notice I mentioned earlier in my talk that when the PSA is rising faster, usually if it's doubled within 10 months, so PSA may jump from 1 point something to 2 point something within 3 months. I mean, that's not enough to change a whole lot of things. But does that patient need a close monitoring? Yes. Are they on other medications that can affect the PSA levels? So those are things that we want to know. If there's a new medication, you want to make sure your doctor is aware of them. So by looking at the PSA, reporting symptoms to your doctors, and regularly scheduled scans where appropriate, where clinically appropriate, those are the ways we can tell that something is wrong and we need to change our strategy. Can all these medications work forever? Well, apparently no. As we've learned from antibiotics, you'll have had instances where they tell you, hey, don't just take these antibiotics, because otherwise in the future when you need them, the bug can become resistant and you're not able to use the same medicine. So we've had super resistant bugs. The same thing can happen with the cancer where it mutates and our drug is no longer working. So in that case, well, we change strategy, but there is no one size fits all, and you can't just say, well, I've gotten my medication, I don't need a follow-up. That's not gonna work.
Great, thank you. So go ahead. Go ahead.
I have a question. Next generation sequencing, which is where they do the genomic full panel on your tissue. My understanding from the FDA approval and the Medicare coverage is that Medicare will pay for that once. Medicare pays once. So that being said, as a medical oncologist, I think you're more knowledgeable about this than maybe some other physicians. How do you talk through that with a patient or look at their situation and help them make a decision on when it might make sense to get that next generation sequencing testing?
Yes, I will look at those categories that I described earlier, where we said, well, based on your risk category, based on the history that we obtained, you should be undergoing this test. So we don't want to waste one bullet. We want to use it when it's appropriate, so we can get all the information that we need. So based on the information that we get from the patient, yes, we can recommend it and then proceed from there.
For example, since we know it has the potential to make a patient possibly eligible for a PARP inhibitor, like Rubraca or Lynparza, when you're right at that point, is that maybe that's a good time to consider it? And I suppose a patient could have had their hereditary or germline genetics tested, but I'm not sure everybody does.
Not everybody does, although the germline testing really doesn't change because it's there. You were born with it, you got it from your parents. So that really doesn't change. And to my knowledge, I don't know that we have a lot of changes with somatic mutations over time. But
I know there can be some. I've heard more than one expert talk about the fact that there can be some, it's not impossible, some changes. So that speaks more to thinking about the timing I guess.
Correct, that's true, exactly. So there could be, and that's why we don't want to just do it for a patient with, for instance, non-metastatic disease, because how is that going to change my treatment? So I want to use it when I really need it, when
Right.
you have metastatic disease or lymph node positive disease. Yes.
So you don't want to do it on your radical prostatectomy surgery tissue. That's not the time. You want to probably look further down the line.
Unless, yes, unless they meet any of these criteria here. So if
Okay.
the patient has other history that suggests it to be useful at that time, yeah, sure, then we can do it.
So
Thank you.
Carl has asked, how often, if you're metastatic, how often should you have a CTC to check, to check your status? And also, how often do you normally recommend that a man who has metastatic prostate cancer have his PSA monitored?
Generally, I mean, depends on what treatment you're on, but 3 months, it's a reasonable time.
That's for PSA, correct?
For the PSA, correct.
Okay.
For the PSA. Again, depending on the disease burden, we don't want to be doing CAT scan every now and then unless it's going to change something. So many times it's actually based on symptoms. But if it's not on symptoms, yes, you do your bone scan, which may change. I know bone scan, now we're talking about more sensitive tests than bone scan. Because there are certain levels of PSA when your bone scan is not going to show you anything. So why do I want to do bone scan for a patient with PSA of 5? Because it's unlikely that I will see anything, unless, of course, if they have a pre-existing bone disease that I'm monitoring. So the time, especially for metastatic cancer, will vary.
Right.
Unlike somebody without metastatic cancer. So it depends on the disease. So somebody with a lung disease, I might want to check on them, maybe say like every 3 to 6 months to know what's going on and then make changes. And if they've been stable, hey, why expose them to additional radiation? So we can say, hey, check it once a year, something like that. So these are conversations that you'll have with your doctor based on the sites of your disease and the severity.
Right.
I think Carl was talking about a circulating tumor cell blood test.
Yeah, I misread that. He's talking about CTCs, circulating tumors. So if you could actually tell people what it is, what role it can or might play, and then of course he's asking about how often should he get it. So thank you.
Do you use it in clinic, Dr. Fawole?
Not yet. Yeah, I consider many of these tests carefully. We get presented a lot of tests, like order this, order that, but I always like to look at the data and see, does it supersede what we know? How will it change my patient's response, or what will it change? Yes, there are a lot of things out there, but I choose carefully how I test. So circulating tumor DNA is not something that I currently use for this condition.
Great. Could you explain to those people who don't know what it is, though?
Well, yes. So that's a blood test where you're looking for free proteins in the blood that is believed to be coming from the cancer cells. So when you do your blood test, kind of like, let me compare it to the PSA, though not exactly the same thing, but you're looking for where are the free tumor cells circulating in the blood. And then the question is, so what do I do with that information? It's one thing I like the word, let me show you here. I hope I have, let me show you here where I say pathogenic mutation or pathogenic variant. I think that's a very key word when you're looking at how do I interpret blood tests or any test results. There may be mutations in the blood that are not responsible for the patient's disease. I don't know if that makes sense. So I can find 10 mutations, whereas only one of them has something to do with the cancer. So I don't want to be all over 9 mutations that are useless. They are there, but they are not causing any disease.
And
going
from
back,
memory, the CTC blood test is somewhere around $1,000, and I don't know how often insurance pays for it, where a PSA might be $50. So I think patients need to ask about that too.
exactly, yeah. So yes, we get presented all of that all the time, and I pay bills, so I put that into consideration when I'm managing people. I'm like, do we really have to pay for that? If there is a medicine that is relatively cheaper and I'm getting the same result, why do I have to get the Cadillac plan? Again, nothing against Cadillac, but for those who like it.
Yeah,
But
and
my
if
point,
if
yeah, but
insurance
the
rejects it,
cost
they
of
have a bill. Yeah.
yeah,
Sorry.
so the cost of healthcare is really important. So I'm always looking at how much will it change what I do? How much will it change the piece of information? So yes, circulating tumor DNA can be useful in certain instances, but with prostate, well, I'm looking into the data concerning that anyway. So time will tell.
So you earlier in the presentation, when you were speaking about genetics, you had recommended that patients bring somebody with them to their doctor's appointment to help remind them that Uncle Sam had prostate cancer or whatever. But I actually would want to expand on that and say that it's really important for people to bring someone to their doctor's appointments, because not only is it we may not remember our family history, we having a doctor's appointment when you have cancer is a high tension experience, and oftentimes we patients, and I'm a patient so I can attest to this, and my caregiver who is on the call will also confirm this. um, we don't always hear exactly what's said, or we hear it a little differently. We also tend to forget the questions or the things that we're concerned about. We may go in with a list of 10 questions and get to 3, and then, depending upon the answers, forget what those other questions are, but they may be very important. So I think it's important to expand that our recommendation that we bring another individual with us to our doctor's appointments. And if you can't, you should ask your doctor permission to perhaps record the session and explain, this way you can have an opportunity to go back and listen later on to make sure you understood what was said. That's another thing, but we always say you should ask your doctor before you do that.
Thank you. That's true.
Any other questions? There must be some questions. We've got 40 people on.
Jan, can you
Hi,
hear me?
Larry. Yeah.
Yeah. In going through this today, they talk about side effects and they reference hot flashes, but you don't hear much about anything else as far as side effects. And I was watching the different numbers and these different new drugs coming out. I don't know if this is a fair perception that the lifespan is increased by 3 months versus something else. Where can you get a feel for, as you go down this path, what your quality of life will be like and whether you want to go down that path? Is there any information available on that view?
I would love to hear Dr. Fawole's input on that. Are you talking about taking, for example, the second-line hormonal therapy pills like Erleada, Nubeqa, Xtandi, Zytiga?
Yeah, I'm on one of those along with Lupron.
How are you feeling?
Aside from hot flashes, I'm feeling fine.
Okay.
But I don't know what happens with all these new drugs that you guys are talking about, which are exciting and they're bringing new hope. What it does to you as you go down that path.
Yeah, thank you. Yeah, another good question. And we, as much as possible, want to go over side effects. And of course, I'm just mentioning, I mentioned hot flashes as an example of, it's a common one. But when we do clinical trials and you ask patients to list their side effects, we also try to categorize them based on the frequency of those side effects, that what's relevant, what's the severity. I was looking through one of the side effects, and one of them is listed leg laceration. And I'm like, okay, what does leg laceration has to do with this drug? The drug did not cause laceration of your leg. It's because you swiped it against the chair, something happened. So again, that's not to belittle side effects that patients report. They are very important. We take them seriously. But we want to see what's the connection, what's the severity? Is it something that you can deal with? Many patients will say, well, you know what, based on the benefits, I'm going to deal with the side effects. And that's where everybody is different. In my world, our goal is to make sure we minimize the side effects. It's always important to us so that patient can at least go through their treatments, especially when they have to take it for years and years. So having said that, that's a conversation that you'll have to have with your doctors when a new medication is being recommended. But even though in our clinical trial, some of what I've shown you today, they can say, well, the median survival is this, or the difference is 3 to 4 months. Again, that's median survival. Everybody is different. In that big basket, you have somebody with, although we try to match them, but still everybody is different. I mean, it's just the real world that we live in. So in that group, you might have somebody who live for 3 years. And you might also find people who live for 3 months. When we're doing studies, we cannot pick and choose. So at the end of the day, the guy who lived for 3 months will dilute the study, and then we come back to the middle. So that's why we call it median overall survival. So that's a lot of statistics, which we won't be going into today, but just to let you know that it's not just, oh, it's just 1.2 months. That's not a lot. Well, again, it's different. I get involved in clinical trials and I can see how it affects different people. Not everybody will respond to the same medication the same way. And not everybody will have the same side effects that everybody will have. So, and your perception of those side effects differs. I have patients, the fact that they come into the oncologist office, they're already nauseous. They already have nausea. So the way I will treat that nausea is different than somebody who's taking the medication and develop nausea. But if you ask them to check their symptoms, both of them are going to report nausea. So it's up to me to figure out, how do I manage that? So side effects, yes, very important. We take them seriously, report them with your doctors, your healthcare team, let them figure out what to do with it. But with the new medicines, I can tell you, having practiced for the past 20 years, I've seen how world has changed, how we've been able to help patients feel better. And with what I see on the horizon, I think it's going to keep getting better.
Yeah. Jan, you mentioned, doctors tend to look at the numbers and look at the results, and the nurses look at the soft side.
I didn't say exactly that way, but I know what you're
Oh.
saying.
Yeah.
But yeah, I do like to tell people to talk to the nurse about the side effects. And if you're with a medical oncologist, Larry, you and I have talked about this, the nurse practitioner or the PA will come in and see you before the doctor. That is a great time to talk about side effects. I don't know, it's just, it works. And if you are getting an infusion, you're in the infusion room, there's another nurse. The second thing I would say is talking to other patients can really be helpful, but you have to be discerning. You have to tell if that person is overly emotional and an exaggerator by nature. This is the world we live in. Or also ask them about their overall cancer situation. Are they in the same situation with you? Do they have the same treatments you've had? Do they have the same overall health that you have? So make sure you're comparing apples to apples and not apples to oranges. But I do think talking to other patients is helpful. You just have to do it with some discernment.
So there really isn't much published or written about.
Well, there is published, yes. But sometimes it's hard to get the discernment out of the publications. I think you need the published plus people. That's my personal viewpoint.
Yeah.
And I think, as I mentioned earlier, side effects are experienced differently by different people, and maybe each time they're on the same round of treatment. and there's no way to predict where you're going to be. I think that's really important. And actually, Mary asked if perhaps the doctor could offer some suggestions, since hot flashes are such a common side effect, some treatments or some ways that perhaps they can be controlled or perhaps softened a little bit.
Not a lot of options, unfortunately, but at times there might be need to do dose change where they can change the dose, reduce it, or adjust things to help minimize side effects. Or maybe use a different medication, because we don't want the side effect to be worse than the malady. So, but that there is, we don't have a lot of options as far as I know in that field.
I'm sorry, was it hot flashes you were referencing?
Well,
Joel?
she specifically asked about hot flashes, I believe. Maybe you can mention ideas to help with side effects such as hot flashes, which is so common. Then she said, Celebrex did not work for my husband, but Megastrol has worked wonderfully. However, we couldn't get anybody to give a patch, even though it works for many. I'm assuming she means an estrogen patch, I'm assuming is what she meant.
Can I comment real quickly on hot flashes? I think, and Dr. Fawole, correct me if I'm wrong, it's one of those side effects that's quite individual, but the treatment is quite individual. There's multiple ideas. So don't get discouraged if you try 2 things and they don't work. You may have to try 4 before you get to them. Low dose Effexor is something that's been in the literature, is helping with side effects and also depression. Estrogen patches, like you mentioned, but you need to talk to your doctor about all these things. Megace, which is Megastrol.
Right.
There's multiple things, and we just had a nurse comment that hydrating helps. So
Yeah,
it's one of those things with just a lot of different ideas.
Yeah, the other thing is that I find from my own experience that sometimes what I do in my world can affect a hot flash. So for instance, if I have a drink of alcohol or some wine, that'll often kick a hot flash for me. If I have spicy food, it kicks a hot flash. I walk around with something, I even have it on my desk now, if I can see it. It's a fan. Got a little portable fan. And if I'm having a hot flash, I just turn it on, and that really helps me. So there are things like that we can do that aren't necessarily medical, and I would rather intervene that way. Diet, alcohol, fans, air conditioning. I mean, some of us like to have arguments with our spouses or our partners as to who's going to keep how many covers on them, but that's an issue that's not in the privy of this particular meeting.
Well, we're close on ending time, but Rob does have his hand up. I kind of feel for Rob since he was diagnosed so young. Rob, you want to squeeze in one more question?
Thank you so much. Doc, first off, man, I fight with my wife for that ceiling fan controller every day. Just kidding. But are you, when we look at the drugs that are on our horizons, I know the PARP inhibitors were like a really big step forward. Is there anything out there that you're looking at that is exciting? If you could just pass on to us for hope for the future.
Anything after what? I'm sorry.
Anything on the horizon that I know PARP inhibitors were just released with olaparib and some of these other drugs. Is there anything on the horizon that you're seeing molecular wise or immunotherapy wise that is exciting that you're watching that's currently in phase 3 or 2 trials?
The last time I was having conversation, we have in my institution, we have a drug development unit, where we do phase 1 clinical trials, phase 1, phase 1B, and some of those drugs have actually gone on to get FDA approval. So from the last time I spoke with them, I do not know what they have on, but I know they said they were working on something, but something comes up every now and then. And when we do have, so that's part of when we see a patient, we are always screening for clinical trial. Is there something out there that is new that they can get? I may not be able to give you any specific now, but I know that, yes, they're always telling me, oh, there's something else going on. There's something And yeah, we're always looking out for them, but if we have, sure, we'll be glad to share them with you, but none that I can remember at this time.
So I'm gonna,
Arnie,
just before we
go ahead.
close, just gonna suggest that people read the chat, the comment that was made by Wendy about giving some other ways to remediate hot flashes. I think it's kind of additional to what I had added. It's non-medication stuff that really does work. So just refer people to that.
And I want to tell Rob to keep in mind that there are new developments every single year. There are big conferences thrown every June for medical oncologists. Everybody's pushing to publish their data at this annual conference. So just count on the fact that there will be something new every year. We don't know what exactly, but that's a staple. Science continues to develop. Okay.
Thank you.
You're welcome. Okay, I think I'll close it out. Dr. Fawole, you want to say a final closeout for us?
Yes, it's my very great pleasure to be here today. Thank you so much for the opportunity to share my ideas with your patients. And please, whatever we can do to help you, feel free to reach out. I do give my email to my patients, and Jan can share them with you. So please feel free. We'll be glad to help, and wish you well.
Thank you so much. Really appreciate it.
Thank you.
Thank you.